have Haider Warraich, who's going, did I say that right? Close enough?
Close enough.
You can
I'll
tell
take
us
it.
yourself. Who is a fellow here in the Division of Cardiology and is going to be talking to us today about heart failure. So, great.
Great. Thank you, everyone. So I'll just start off by saying that this is a really tough topic, even within heart failure. So I've tried to talk to people about interns, residents, medical students about this, and it's not. One session is never going to be enough, just because it's a complicated and sort of challenging topic, but because it's such a big and prominent disease state, and I think DCRI actually has ongoing active registries and trials in this population. I thought this would be a good place to start for everyone. I think the key thing is, I'm a physician, clinician, cardiologist. This is all I know, and if I say stuff that you don't know, just stop me. And just tell me to be like, whoa, slow down. So, I wanted to take the opportunity to really first talk, give you an outline of what I'm going to be talking about. So really, I think the first thing I want to talk about is, just what is heart failure, and then we can talk about, well, what is HFpEF. And then I wanted to talk a bit about diastolic heart failure, because you also hear this term used kind of sometimes interchangeably, and I'll explain what that means. And then about diastolic dysfunction, which is another sort of component of HFpEF. And then also lastly about, how do we treat diastolic heart failure or HFpEF. So, I think the first thing to ask is, it sounds like a basic thing, but it really isn't. The question is, what is heart failure? Any takers? Just rough estimate. Like if someone asks you, or if if you're walking in the street, someone says, "What's heart failure?" What do you say? And this is hard. I mean, like we don't think about this enough.
Obstructive flow of blood.
Right. So some type of problem of blood going to the rest of the body, right? Either not going enough to the brain, the kidneys, etc. But I think the key thing to think about and to know is that, so this is the definition. So heart failure is a clinical syndrome that impairs the ability of the ventricle to fill with or eject blood. So heart does two things. One is so heart's here. Heart pushes blood forward. So heart sends blood to your brain, which is why we can think. Heart sends blood to the kidneys to keep them nice and flushed. Heart sends blood to our muscles and to our legs to keep them functioning. But then the heart does the other thing. It also flushes blood out, right? So the heart, the reason why you don't have blood just sitting in your legs or sitting in your lungs is because the heart is also, taking blood in and filling itself. So those are two components, and that's important to think about. And the other thing to know is that, heart failure is really the end game of all heart disease. So almost any type of heart disease you have, in the end, eventually, you will develop heart failure. So for example, if you've had a heart attack, your heart becomes weak. Eventually, it'll lead to you having heart failure. Not everyone with heart attacks will have heart failure, but if you have enough, you will get there. If you have any type of valve disease, for example, if the valves, which are like the doors in your heart that blood keeps flowing through, if they become tight, so something like aortic stenosis, that will also cause you to have eventually heart failure. So really, it's sort of at the end of the funnel where you start off with sort of milder forms of heart disease. A lot of them, in the end, all end up looking the same as heart failure. The key thing here is that it's a clinical diagnosis, and I think this is important from a clinical trial design as well. But it's hard to just and the symptoms of heart failure are really the symptom. I mean, if you think about what the heart does, it's a failure to do those things. So one of the key things that happens is that one of the key symptoms is shortness of breath, which we call dyspnea in medical jargon. Why may that happen? So what happens is the heart has to do, one of the important things that the heart does is that the heart keeps blood flowing forward, preventing it from sitting in the lungs and kind of leaking blood out into the lungs, which causes something called pulmonary edema, which is basically water in the lungs. That's one of the key symptoms of heart failure. Because the heart is unable to flush blood out effectively, you get leaking of water out into the lungs, resulting in pulmonary edema. And that's why this is the number one reason why people with heart failure will come to the hospital. They'll come in short of breath. And that's also one of the key things about, that's what also it makes heart failure hard to manage at home. Right? There are a lot of things that we can do to take care of patients at home. So for example, if you have cancer, if you have a lot of pain, we have if you have good pain medications that can take care of that. But it's just hard to sit at home with someone being really short of breath. There's really nothing you can do. That's why heart failure hospitalization is like such a huge thing. Fatigue, and this fatigue can happen because of many things. Sometimes it's not enough blood going to the brain, so people get confused and tired, but also that you're not doing enough, that when you work, you develop, your muscles create these things called, they create what might be considered toxins, or basically acid. And if you're not doing enough of a job flushing them out, you get progressively weaker. Exercise intolerance and fluid overload is really, blood or water will pool in your legs because blood just sits there for a long enough time and just leaks out water. So the key things I think for you all to remember is that fluid overload is a very common reason why patients with heart failure will come to the hospital or get sick, just because they'll get fluid in their belly, fluid in their legs, etc., etc., and also shortness of breath from water leaking out into the lungs. So what are the types of heart failure? So really, the first type of heart failure is systolic heart failure, aka HFpEF, aka heart failure with reduced ejection fraction. Now let's break this down a bit. So there are two parts of the heart cycle. One is systole, which is just compression, contraction. That's when the heart squeezes and sends blood to the rest of the body. And the other is relaxation, which is also an active process. The heart spends energy. It just doesn't relax like a balloon. It actually has to spend energy to relax, to suck blood in. So even though we think of relaxation as almost a passive thing, but the heart actually has to spend energy just to relax and get blood, just to fill itself. And in systolic heart failure, what happens is that the heart, which kind of squeezes like this, and the ejection fraction is how much of the volume in the heart, or the left, in the part of the heart that pumps, is actually pumped out. The normal is greater than 55. Sometimes some people say 60, but really greater than. So a normal heart will squeeze 55% or half of its volume forward every time it contracts. Anytime, and that thing is called ejection fraction. It is a fraction of blood that the heart ejects every time during contraction. Contraction is called systole. We have complicated words for very simple things just to make us sound smarter. So how can you tell if someone has, and so this is what has been the traditional type. When people think heart failure, this is what they think about. They think that there's something that the heart isn't squeezing enough. So normal heart does this. The sick sort of like reduced ejection fraction is kind of doing this. And it's not pumping enough blood forward. This is really what is the classic form of heart failure. So when people think heart failure, this is what they're thinking about. They're thinking the heart's just weak from having had multiple heart attacks, some type of other sort of insult that's accumulated to the point that it's just become very weak. It's doing a bad job of pushing blood forward. How do we assess ejection fraction? Is by echo, ultrasound of the heart. So you put an ultrasound of the heart really, and you kind of see how much it is squeezing. There are other ways of assessing ejection fraction, but really echo is what we use most. And there's no objective way of saying, the computer doesn't spit out a number. The vast majority of how we assess ejection fraction is really cardiologists such as myself looking at the echo and just saying, oh, this looks normal, this looks like it's 35%, this looks like it's 15%. And to date, we haven't been able to come up with something better. So I think this is something to understand. And the other form of heart failure is what we call heart failure with preserved ejection fraction. This is a newer diagnosis. What happened is, when people started studying heart failure initially, everyone was just looking at this first thing because this was just easy to look at, easy to assess, and these patients generally were a bit younger, a bit sicker. And then what started happening was that we started finding patients who came in with heart failure symptoms. So again, heart failure is a clinical diagnosis, but who had a normal squeeze. So we couldn't really get a sense of, well, how is it that patients have the same type of symptoms, they have the same heart failure symptoms, but their heart's squeezing normally. And so in essence, we almost had to come up with this diagnosis to just explain who are these patients who have heart failure, but their hearts actually appears to be squeezing normally. And so this whole category was basically called heart failure with preserved ejection fraction. One of which, and one type of that, is diastolic heart failure. Any questions? Yes, sir.
Question. You said the normal is like 55%. What is it when it gets abnormal? What's low?
So again, that depends on what study. So we'll look at those numbers as well. It depends on really the trials. Most people say less than 35. Some people say less than equal to 35. Some will say less than 30. And then in the advanced heart failure space, really, really sick people, depends on the trial. But really, I think how I think about this is that if you do not have a normal ejection fraction, so I would say you can even expand it, less than 50. So if someone says you have an ejection fraction of 50% flat, that's actually not normal. Because what we do when we say greater than 55 is we're lumping together a lot of different percentages. We're lumping together the 75s, the 70s, the 65s, the 60s, all together because it looks grossly normal. So I would say anything 50 or less with symptoms is systolic heart failure. Having said that, most trials, because the trials want to have patients that they think will have events. They want people who are sick people. So a lot of the trials will include EF less than or equal to 35. We talk about that in the next slide. Any other questions? So we talked about what is heart failure and types of heart failure. Yes?
Curious, based on these numbers, is it possible that your heart could actually pump out 90% or?
So yeah, so sometimes
what is that?
Sometimes we see what we call a hyperdynamic state. Younger people, people who are if I put someone on a treadmill, if someone has a lot of blood volume, a lot of times in pregnancy states we see that the heart is actually kind of like hyper functioning. So yeah, the heart can be extremely efficient. I think 90 is, I don't know how many hearts would go up to 90, but I'm sure many could get actually close to that. Sometimes that's a problem. So for example, some people, I don't want to make this too complicated, but for the most part, it's fine. Most part, it's if a heart's is really sort of hyperdynamic, it's really a normal response to some type of thing. Sometimes it can be sickness. So sometimes when people have infections, your heart rate goes super fast. So it's actually responding appropriately to your body's demands. If you're dehydrated, etc. So there are a lot of different things that can cause that. Yes, ma'am.
So is that, are you aware of that? I mean, I would think that if your heart is above kind of the normal 55, that you are feeling that.
So you don't. So the two things you can feel. One is you can feel a fast heart rate. So your heart's just going fast. It doesn't tell you if it's actually pumping more than it should. And so you can feel if your heart rate's going fast, if you're about to give a speech, and it's going like duk, 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 you can feel that. It doesn't tell you about if it's actually pumping more than it should. It probably is, but it's hard to know. The other thing is that a lot of people are just very sensitive to, or sometimes become in some moments of stress or anxiety or just normalcy, they can become very aware of their heartbeat. So sometimes kind of when you're trying to sleep and you can't sleep and you can really feel your heart. It doesn't say, I mean, it's just a sort of like sometimes it can be a totally like random awareness of your heart. Most of the times we're doing work, we don't actually think about what our heart is doing. We don't actually feel it. But there can be times in which you can become aware of it. It may or may not have anything to do with what your heart's actually doing, more to do with the fact that you're just actually really thinking about it and really feeling it. Other questions? Okay, I want to keep this real basic because I think, okay, so systolic heart failure or heart failure with reduced EF, how do you define it? It's signs and symptoms of heart failure and a reduction in ejection fraction. Everything is kind of in the name. And again, as mentioned, it's variously defined as, either anything less than normal, so 50 or lower, so anything that's not normal, or in some trials, in actually most trials, especially that are pertaining to heart failure, it's more close to less than 35 because you really want that population to be, you don't want a sort of loose population, you want a tight population in which you think you know what's going on. And then ignore this, I'll show you a picture for this. And then the other type is heart failure with preserved EF. Now again, if you think about it, heart failure with preserved EF is not really a biological phenomenon. It's really an inability to classify these patients who have heart failure symptoms, but you don't have a clear way of understanding them by the means that you have available to you. So the means that we have available to us is ultrasound of the heart, showing how strong is the heart beating. Now, this is just, we just came up with this patient population who have symptoms, but by our measure, they didn't have any sort of clear abnormality, so we grouped them together. So that's one of the reasons why this is a difficult group to study, because potentially you could actually have a very heterogeneous population. You could have people with many different things, but we have put them in this basket of heart failure preserved EF. And if you look at how it's defined, it basically constitutes 50% of all heart failure patients. So this is a big population. This isn't a small population. Half of patients will come in with heart failure that have a normal ejection fraction on echo. And again, from a symptoms point of view, they're exactly the same. So the symptoms will not tell you if the patient has preserved ejection fraction or has a normal function, is pumping normally or is not pumping normally. At least from a contraction point of view. So that doesn't really help you. And there's a lot of differentials, ignore everyone, but really the main cause of HFpEF is what is called diastolic heart failure. Has anyone heard this term before? Okay. Some people use this interchangeably. Some people say diastolic heart failure, HFpEF. I want you to think about HFpEF is a big group of everyone who has heart failure with normal EF, and diastolic heart failure is a very big part of that group. But they're not to be used interchangeably because you can have HFpEF for reasons other than diastolic heart failure, and we'll explain what diastolic heart failure is. So let's go right into it, because really this is what we really know scientifically about HFpEF. So I mentioned systole, which is the pumping of the heart. When the heart isn't pumping, what is it doing? It's relaxing, and that's called diastole. Again, we could just come up with simple names for all of these, but we just have all these sort of additional technical terms. But really, that's the part. And even though when you think about relaxation or when the heart is relaxing, you really think about this as really a very passive thing. It really isn't. The heart actually needs to spend energy to be able to relax appropriately. And really, if you look at diastolic heart failure, again, these are patients who have heart failure symptoms and have evidence of some abnormality in their contraction, which sounds crazy. Like what could possibly go wrong with contraction or just relaxation of the heart? And really, this is what this is all about. These patients, at least in epidemiologic studies, are older patients. They're more likely to have hypertension and they're more likely to be female, and that's just the epidemiology we have. I would ignore this. So this is kind of a, so I would just, so these don't show well, so I would just focus on the pictures on the left. So look at the normal, so this is the middle picture. So, so if this is your heart, what you're doing is that you're actually slicing the heart and looking at it like this. So for example, if this is your heart, you just sliced it like a bread loaf, and this is kind of what it looks like. This is the left side of the heart. So let's just focus on the normal. This is the left side and this is the right side. And really all the pumping is done from the left side. All the relaxation is done from the left side. So this whole discussion is just about the left side. The right side doesn't do as much. What happens in systolic heart failure, again, this is the ones in which they're not pumping enough. It's just the heart's just not doing. The heart becomes big and thin, as opposed to diastolic heart failure or HFpEF, in which the heart really becomes thick and chunky, but doesn't become big or the walls aren't thin. So this is like one thing to think about, one thing sort of how they're look pretty different. Ignore this. And what causes diastolic heart failure? Things like hypertension, diabetes, heart disease, etc. But nothing, I'll skip this too. So I wanted, because I wanted to keep this basic, I really wanted to focus on what really is diastole. And there are two aspects of diastole, and we'll just talk about the concepts. We won't actually get into the nitty-gritty. But there are two concepts. One is relaxation, which is basically if a muscle becomes real tight, how easy it is for you to just get relaxed and then go back to its sort of nice big shape as opposed to being contracted. And the other is compliance. So compliance is another interesting concept we'll talk a bit about. And HFpEF, or diastolic heart failure, really is an abnormality in one of these two issues. So one thing to think about is that relaxation is an active component. The heart actually has to spend energy to go from a contracted state to a more sort of like larger relaxed state so that blood can get into it. The other concept is compliance. I mean, so compliance is so one way to think about compliance is, for example, if you have two types of balloons. One is made of one is a balloon that you've blown up many times, so it's kind of become loose. So if you add any type of volume in it, the pressure in that balloon won't go up that fast because it can accommodate, it's like loose and it can accommodate a lot of fluid or air, etc. But then you have this balloon that's real tight, that's like totally new, and it takes you a lot of energy to just fill it up. Because as soon as it sees any volume, the pressure goes up very, very quickly, and it kind of fights you. And that's really what compliance is. And it's almost a characteristic of that balloon, or in this case, a characteristic of the heart. And this is more of a passive process. So I'll pause here before going forward. How are we doing? Any questions so far? Okay, but these are the two main sort of conceptual things that go wrong. I won't get into the whole sort of details of how that works, but really I think the key thing is that that diastole or relaxation is a dynamic and energy-dependent process. And what happens is that the left side of the heart, the pumping chamber, which is the left ventricle, which both these types of heart failure discussions are all focused on the left ventricle. It basically untwists and then creates a gradient. It actually pulls blood towards itself and it sucks in blood. And the inability to do that and the inability to relax is what actually results in heart failure. What basically happens is that even though it ends up contracting fine, when it relaxes, enough blood just never fills into it for it to be able to push enough forward. So even though whatever blood is in there, it's able to push that forward fine, it just never gets enough blood in the first place because it's not having a good ability to get blood in and relax and to be able to fill appropriately at the same time. So even though contraction is fine, it's just that when it relaxes, it just doesn't fill enough or adequately. We'll skip this too, just because this is kind of irrelevant. And diastolic dysfunction is really an abnormality in either one of these two things, either relaxation or the compliance of the left ventricle. And so some of this happens because of aging. As we get older, the elastic properties of the heart and your blood vessels actually goes down. Everything kind of just becomes a bit stiffer. And that's why your blood vessels become stiffer, your heart becomes stiffer. So some of this has to do with getting older. But not every old person will get diastolic heart failure. Not every old person will get HFpEF. So that's why there is something that's different about these patients than it is just being elderly. So one of the big things that happens, and this is kind of always looked at in clinical trials, is that when in HFpEF, almost universally, the heart walls become thicker. Just because the heart is like any other muscle, if it has to do extra work, it usually will grow in size. But that may not be a good thing. This is sort of the heart kind of on its side. This is your chest, and this is the heart kind of sitting like this in your chest. And this is the left ventricle, this whole thing. And this is the aorta. So basically, blood enters the left ventricle and then goes to the rest of your body. And if you look at the size of this thing, this is really what is dry. The left ventricle is the most important structure in the heart, because this is the biggest structure, the most muscular structure. This is what's doing all the pumping. All the others really, in some ways, just support the left ventricle. So one thing that we see is that these muscular walls of the left ventricle here just become bigger. This is almost something that we see almost universally in patients who have this. I can ignore this too. This is just how kind of blood flows into I just figured that it's just kind of beyond this, I think, the scope to really talk about some of this stuff, even though this is fairly basic. So one of the things that I also wanted to talk about, which is also easy to understand, is so the problem with diastolic dysfunction is that it's really hard to assess. It's really hard to get people to agree with measures that are consistent across populations, because what you're doing is we have retro-engineered this entire science. This entire science exists because we had this whole chunk of people that we didn't understand, and then we've gone back and tried to figure out, well, what could be going wrong with them? So one thing that I talked about was that, one thing that's consistently found is that the walls of the left ventricle, which is the pumping chamber of the heart, get bigger, which in medical jargons mean hypertrophy. It just becomes larger. The other thing that happens is that the small chamber of the heart, the left atrium, which doesn't do any pumping function, but which acts as like this reservoir which fills with blood and then goes into the left ventricle. When this part of the heart sees a lot of high pressure here for a long time, the size of the left atrium becomes larger. Just because it's seen so much high pressure and it has to accommodate all this extra blood volume, it just expands in response. And that's one other sort of consistent thing that's found in diastolic heart failure, is that the left atrial size becomes larger. And that is actually referred by many as kind of like the Rosetta Stone of diastolic heart failure. And does anyone understand like just basic diabetes stuff here? So there are two ways. So it's sort of thought about in diabetes. So there are two main blood type. There are two main ways to assess diabetes. One is to check your blood sugar. So I can check everyone's blood sugar, and if it's above like say 200, I can say, oh, your blood sugar is high. But it gives me something that's very immediate. It doesn't tell me how bad it's been over say the past 3 months. So there's another type of lab called an HbA1c, which gives you sort of more of a long-term sense of, well, how has this person's sugars been over the past 3 months, as opposed to what it is right now. And the reason I say this is because the left atrial size is really considered as the A1C of diastolic dysfunction. It gives you a more sort of long-term sense of how the patient's been. And at least in studies, it's been associated with a higher rate. So the larger your left atrium is, the higher your risk of dying, heart failure, stroke, etc. So now we come to perhaps what is the most difficult part about this whole area, this whole space that affects 50% of all patients with heart failure, which is a very common disease, is that we don't have any good treatment for it. And that's like super frustrating. Really, if you look at the guidelines, what I want you to focus on, this is, so class 1, so this is how most guidelines are these days. There's a class recommendation, and then there's a level of evidence. Look at the level of evidence for all the, I mean, the fact that you can't read it is moot point because they're all level of evidence C. So all the recommendations we have for heart failure, we have no evidence for them because what happened is, so we have all these great drugs for heart failure, like, I don't know if any of you work in heart failure, but ACE inhibitors, beta blockers, and then we have devices like pacemakers for certain types of heart failure. We have ICDs or defibrillators. We have, and then more advanced things like heart transplant, like LVADs, which are pumps that actually sit on your heart. All of those therapies, which are all great, are all for patients with reduced ejection fraction. So what happens is, a company does a trial and a drug works in reduced ejection fraction or patients who have systolic heart failure, people whose heart doesn't pump effectively, and then they've done trials of all those drugs in the heart failure with preserved EF, the HFpEF population, and guess what? All of them are negative. So right now, we don't really have any sort of specific, there's some drugs that, in small studies have looked at, had some effect on some sort of secondary endpoint, but really, if you think about it, we don't really have any medications that reduce mortality in patients with HFpEF, which is awful because it affects so many people, and as people get older, the proportion of people who have HFpEF is going to actually increase, which is why there's so much interest in trying to really focus on these patients and come up with good trials and come up with new medications and therapies that can affect them. So really, there's no great randomized trial data. So this is, again, all this stuff is expert opinion and doesn't really matter if you're within. So one of the concepts that I wanted to kind of leave you with is also this idea that systolic and diastolic heart failure are actually part of kind of the same spectrum. It's very rare to what we've done is we've tried to dichotomize a biologic process, but biological processes don't really exist in most, or at least most biologic processes. They actually are present more in a normal distribution rather than as A or B. And what we have done really is in trying to really simplify our trials and in trying to simplify our disease processes, we've dichotomized these two processes based on the limitations of what we have of really assessing them, which is ultrasound. So in some ways, even though our current classification has practical benefits, it actually does not serve us from a biologic point of view because there's so much overlap. So many people whose hearts don't contract well also have problems with relaxation. And so many people whose hearts don't relax well actually have issues with contraction that we just can't see on ultrasound. So some of this is just that we just don't know what we are treating. Our populations are so heterogeneous that you give one medication to patients that you think are one but are actually 10 different types of patients. And so things don't work. And I'll end this with saying, well, why do we care about this? Is because heart failure by itself is a leading cause of hospital admissions annually. That's a big deal. And one of the reasons why that happens is that heart failure is just one of those diseases. It's really hard to manage at home. And there are a lot of things that happen, and we can come up with great plans to take care of people at home. If someone comes to the emergency room, we can come up with a good plan, and they can be taken care of at home. Or they come to clinic, and we can do certain things, and we can take care of them at home. Heart failure is just hard, which is why there's not only is there a big human burden, that there are so many patients and so many families who are affected by this. But also there's a huge economic burden of heart failure. Our health system is already on its last legs. I mean, we are having all these discussions about, health insurance and stuff, and really, it's just, this is the sort of thing that it would be great to be able to come up with a good fix for, and HFpEF is half of this. And the other thing that's kind of interesting is that, heart failure in many ways is a modern disease. Not many people had heart failure 50 years ago. Why did people not have heart failure? Because if you had a heart attack, you died. And that's it. You never grew old enough to actually live with heart failure. We didn't have people living to older age, so we never had people with heart failure because people died of other things like, TB, malaria, malnutrition, etc. But now, we've had so much great success in helping people live long and healthy lives that at some point they develop heart failure. So, as our population ages, this is going to be an important problem. So, all of us who are involved with this, I think it's a really tough problem to fix, but I'm, glad we're all in it, and we're at a great place. This is one way I want you to think about, this is one way to just conceptualize what is the life of a patient with heart failure like. So this is what they've done is they've looked at hospitalizations over time. What happens is that when first people get hospitalized, when heart failure is first diagnosed, you have this initial period in which you get a lot of testing and people are trying to figure out what's the right medication for you, et cetera, et cetera. So you have this initial spike. And then you have this area of stability in which really, with medications and with therapies, et cetera, you have stability. And then at the end, before, people pass away, there's this huge spike in hospitalizations, close to sort of at the end of life. And so one of the things that I'm passionate about is something called palliative care. Does anyone know what palliative care is? Okay, so palliative care is basically a form of, is a sort of a philosophy of care in which, at some point you decide, well, more sort of life-sustaining therapies or more sort of like, devices or procedures at that point. Like, for example, like if you're in this stage, right, what's that saying is that, doing more pacemakers or heart caths or surgeries is not going to help you because you're really at the end of your life. So really one of the big things that, I'm personally passionate about, and I just wanted to, is that a lot of people and a lot of physicians, a lot of patients, end up thinking about the philosophy of care, which is called palliative care, in which really what you're doing is you're foregoing what may be, we don't know, are life-sustaining therapies because people are already here, so there isn't much you can make a change in, and you focus more on symptoms and well-being, quality of life, and being close to home, etc.
I have a question about the graph. Could you go back just one?
Mm-hmm.
So as you're getting into the 16, 18, 20 months, are the symptoms then noticeably worse as well? So the quality of life is really horrible at that point.
Absolutely. Hospitalization is almost I think about this almost kind of like a biological marker in heart failure, because the reason people get hospitalized may be different, but it all is an accumulation of symptoms reaching a point where you can't take care of it at home. And that is why, and that's particularly important, or particularly visible in patients with heart failure is that, so many studies in which we define heart failure is actually by hospitalizations. If you've had 2 or more hospitalizations, you have heart failure, or you have advanced heart failure, because it's really a marker of how bad the underlying illness has gotten, that you're unable to manage it at home. And really, you're right, and quality of life gets worse, mobility gets worse, there's increased frailty, dyspnea gets worse, etc. So all these things do kind of escalate after this, or not everyone follows this, but I think this is a decent representation of what sort of the natural history of heart failure in general is like. And this doesn't matter if you have preserved EF or reduced EF. But this is kind of an interesting sort of graph to keep in mind. Other questions?
I have a couple of questions, not about the graph.
Sure.
But, so obstructive hypertrophic cardiomyopathy,
Uh-huh.
is that the same thing as the left ventricular just getting thick? Is that just a fancy, I'm getting caught up on fancy terms with my files, so.
No. This is a good question. So basically, so what happens in hypertrophic obstructive cardiomyopathy? So the answer is all in the word. So hypertrophy means big. Hypertrophic obstruct. So basically, what happens in hypertrophic obstructive cardiomyopathy is, so if I take an NBA athlete, if I take one of these like Duke kids and I look at their heart's going to be, their walls are going to be thicker than my walls. It's just like anything else. They work their heart more, so but that's a normal reaction to work, and that's reversible. When they stop working, they can the walls actually go back. Some people have a congenital sort of something that they're born with, in which their walls are really, really thick. So they have hypertrophy. And now one thing to look at here is that, so this is the left ventricle, so it's pumping blood, and blood goes through this into the aorta. When the wall becomes too thick here, you can actually get obstruction here. So what's happening is that the walls become so thick that the very thickness of their heart actually causes obstruction of blood flow from getting out. So they can have heart failure symptoms with very thick walls, and there are people who can be, so your question about hyperdynamic, when is that abnormal? So these patients are actually very hyperdynamic, and that's an abnormality for them. So they will, so these are patients who are relatively younger because many of them are born with it. It can be a cause of sudden death, and how sometimes you hear about these young athletes just dropping. One of the causes for that is hypertrophic obstructive cardio heart myopathy, abnormality with the heart. So really everything's in the name. Hypertrophy, large, obstructive, obstruction, cardio heart, and myopathy is really, myo is muscle, pathy is just abnormality with the muscle. So even though it looks big, it's actually abnormal. Yes?
You were talking earlier about the ejection fraction and the marker, or like being less than like 35% would be of interest. Does that change in a person like through the course of a day? Like, like if you measured me in the morning when I first woke up, but then maybe by the end of the day it gets worse, does it have that kind of variability?
It's more stable than that. Okay. It's not like, so it can change. Sometimes it can change quickly if something happens. So for example, if your ejection frames between now and night, I would be worried that, have you had a heart attack or something? So there's some progressive decline in most patients who have abnormalities with heart failure, but it happens over weeks, months, years, sometimes decades. Sometimes it can be stable for decades. But it shouldn't happen during the course of the day. And if it does, then that's sort of a cause for concern. Having said that, the problem with ejection fraction is not that it can change on a day-to-day basis, but it can be read differently by two different people. That's a huge problem in ejection fraction, is that if you put two people, very, very experienced people, and have them look at the same ejection fraction, they may give you different answers. Unfortunately, we have not been able to come up with anything better than that so far to assess heart failure.
Well, and it seems like not only that dynamic, but then you talked about grouping all the HFpEF people together, and it seems like, is there kind of focused effort in trying to identify the distinctions between that big group?
People have tried to use different things. So what we're trying. So one way of saying is that, is there a good way of phenotyping HFpEF patients? Is there a good way of understanding who are the different types of heart failure patients that we are lumping together in HFpEF? People have used all sorts of different things. People have used, machine learning and other statistical sort of ways to sort of come up with these clusters of patients, but really we haven't been successful. If anything, what we have done is every few years we actually change how we define diastolic heart failure. So the guidelines will change, and a lot of patients with HFpEF cannot be categorized into one category or another. What we're trying to do is and that's what happens when your knowledge in biology is lacking, but you have a lot of epidemiologic information, right? And what you're trying to do is you're trying to put together these epidemiologic clusters, and then you introduce a biological molecule to them. And it doesn't care if all these patients are HFpEF. It just cares about the physiology and what's going wrong. And that's, I think, one of the main reasons why our therapies are still lacking. Yes, sir.
Sometimes instead of heart failure, I heard congestive heart failure.
Yep, same
Is that the same? Is there a non-congestive heart failure?
No, it's an older term. But people still use it. They don't use it consciously. They use it. Some people say advanced heart failure. I mean, a lot of loose terms are thrown around.
Another question. Sometimes trials are acute heart failure, another are chronic heart
Yep.
failure.
Yep.
All the things that you talk about was chronic, or is it?
So all the things can happen in the acute or in the chronic. So you can still have leg edema, whether you come, and it really is the acuity. So for example, and that's the difference between those trials is the acute heart failure trials are looking at patients who are coming to the hospital sick, who have had something, who were in that sort of stable zone, and then something happened and they got sicker. It's really an exaggeration of whatever symptoms they had. Most of the times it's because of shortness of breath, because that's one thing that, as soon as you have, most people, as soon as they have, they will, seek some type of medical care. The chronic heart failure populations, they may have they may have like poor exercise tolerance, so they can't get around much, or they may have leg edema, etc., or they may have some impairment in how they're breathing, but not that bad that they need to go to the hospital. So those are patients. It's basically they're mostly enrolled from clinics, and the acute heart failure patients are really your sort of hospitalized patients who come to the emergency room, come to urgent care, or get hospitalized. So it really is a continuum. They're not different disease populations in general.
Say that the acute heart failure patients are really at the end of that curve that you show.
Potentially, I mean, again,
From the beginning.
Yeah, they could be either, and then even in the middle, you can have, there are a lot of things that can kind of tip you over from being sort of stable into unstable. There are a lot of factors that some are reversible. Like for example, someone had a lot of salt. Salt, takes in a lot of fluid. Your blood pressure goes up, and suddenly they're in heart failure. Or they had a lot to drink, and next day they're in heart failure. Or they had a heart attack, and now their heart failure is worse. Or they have atrial fibrillation. That's the heart's going super fast, and it's unorganized, and now they're in heart failure. So a lot of things can tip a chronic patient over. That may be something that maybe it's a marker that they're at the end of life and they're getting really, really sick, or that they did something that's really not a pattern. It's just something that kind of happened that was very focused.
So you mentioned in one of your slides that for the diastole that there wasn't like clinical trials going on right now? Or
No, there are a lot of clinical trials
okay.
going on. That's not the problem. It's
Okay.
just that we just don't have great therapies for it.
Okay.
Yep. We have trials going on here. We have a heart failure network trial called CHART, which is looking at diastolic dysfunction in these patients. So unnecessary. It's more of a registry than a trial. But yeah, there's no shortage of work or interest in this area, because if something works, that's like the market's yours. That's 50% of heart failure patients, right? I mean, you're going to be but the problem is nothing's worked. Yes, ma'am.
Is there any association with different types of MIs and being more associated with preserved EF?
So MIs are traditionally associated more with reduced ejection fraction. Just traditionally speaking, what happens is when you have a heart attack, you have restricted flow of blood to a part of your heart that becomes scarred, because scar tissue becomes dead, and then it kind of becomes thinned out. So that's why you have like these thin, big, floppy hearts in patients who have reduced ejection fraction. So there is more of an association with heart attacks in general with reduced ejection fraction than diastolic heart failure.
Is there any way to quantify the diastolic population for the HFpEF? Like what percentage of the HFpEF are diastolic dysfunction versus?
I don't know if someone's done that. I'm guessing that it's gonna be most of them. Yeah, it's gonna be like 90% of them, because the other causes are not. I mean, you can separate them out too. The problem is that a lot of patients with HFpEF, they may have some elements of diastole, but they don't fit all the criteria to be in one category or another. There are a lot who are just unclassified. So but it's the vast majority of them. That's why I think people feel comfortably interchanging those two terms, but I think it's just good to just conceptually understand that you can have HFpEF and have no abnormality in your diastole, noted that we know of. Yes, ma'am.
A couple of us work with the echocardiogram lab.
Mm-hmm.
So I'm interested in, like you said, one way of measuring the diastolic heart failure was looking at the left atrium size. Like, what are the other common measures that you could try to create those phenotypes?
Sure. So, we talked about left ventricular hypertrophy is one people look at. I kind of skipped over those. There are a lot of things that you can do in which you can see how much the tissues of the heart move. So when your heart squeezes, not only does it close, it actually gets pulled down. So it's basically, this is what there's a spiral motion, there's an inner motion, and there's a pulling motion. So this is what your heart's doing every single time it contracts. And this vertical motion can be assessed using ultrasound, and it's used fairly consistently in a lot of studies to see the stiffer hearts don't really have that type of vertical motion as sort of less stiff hearts do.
What's the measure called?
So it's called tissue Doppler. And the value that they get is E prime or A prime or EA ratios, etc. The other thing that they do is also they look at the flow of blood in the mind. So this is actually right here. So so one thing that they do is, let's see if I have tissue Doppler here. Yeah, so this is what they're doing. This is tissue Doppler. Yeah, so what they do is, so this is your echo image, and they put the marker here on the left side of where you have this valve, which opens into the left ventricle. And then they get these waves which show how much did the tissue move. And when the amplitude of this is reduced, there's a sense that it's really not moving much and it's stiff. The other thing you can do is you can actually look at the pattern of flow from the left atrium, which is like this small chamber right before your sort of big chamber, the left ventricle, and actually see what is the speed of the flow across that valve, how much pressure is it working against, and then there are all these different patterns that can be used to give you an additional sense. But again, no one measure is perfect. That's why all the classification, they'll have like 4 different things that you have to meet. And what that tells me is that really, that's not biology. What you're doing is you're really trying to put together these clusters of information or patterns and trying to make sense of things. I like left atrial volume, I like left atrial size, I like LVH, left ventricular hypertrophy, and actually tissue Doppler, which is the E prime or E to A ratio is actually fairly good. So LVOT is a left ventricular outflow tract, and it really is, so left ventricle outflow tract, so it's this part of the heart. So it's really the part of the left ventricle right before the blood goes out of the heart. So it's right here. And that's where a lot of the patients with hypertrophic cardiomyopathy will have LVOT obstruction. All righty. Okay, great. This is fun. Thank you. Yeah, I literally have to run.